Hello and welcome to the seventh module of HSM 220, and for today we are discussing Affordable Care Act and public health. There are three learning objectives. First, I'm going to describe health policy environment before ACA, describe some key features of ACA, and then lastly going to describe a few key features of the expanded Medicaid and the expanded CHIP program post ACA. So starting with pre-ACA. So before ACA happened, the United States had a couple of health policies that had been, had been passed on. The major ones are the ones that I'm going to talk about now, and it's going to start with 1929 with Theodore Roosevelt, who championed the national health insurance. National health insurance, and also we have 1935 with Franklin Roosevelt, who pushed for a national health insurance like his predecessor did, and also Social Security Act. Then we had 1942, and whether the businesses competed through added benefits to kind of include something that became employer-based insurance. And then we had in 1945 with Harry Truman also making an attempt to push for a national health insurance program. That didn't work. We had Medicare and Medicaid that was passed into law in 1965. Then the Nixon, they try to put some kind of national insurance, but this time going through private insurance. This happened in 74 rather. In 76, Jim Carter pushed for mandatory health plan. 1986, you had the COBRA. 1988, you had Medicare was expanded to include prescription drugs. In 1993, Hillary Clinton did try to champion a policy change to have businesses cover their employers' healthcare costs. In 2003, Medicare was it was then expanded even further to include the drug coverage, prescription drug coverage, and not much happened till then until 2010 when ACA was signed into law. So that's been some years of a lot of changes that has been made, but you might notice that since 1929 to 2010 that one theme that was kind of running across all of them is that anything that had to do with in some kind of national health insurance in whatever style they try to push it always failed. So the United States have consistently refused to pass national health insurance programs. So the reason for the many failed attempts that have been made at a national health insurance is, quite complex in nature. Well, for the one thing, trying to pass a national health insurance is a bit complicated, especially with the way the US is, where the states are quite autonomous and they get to make decisions for their own residents. So trying to get a national plan that works for everybody does present some complexity. And of course, and that's also, you have the issue of the decentralized congressional power, and then you get into the muddy waters of ideological differences, particularly when you compare the ideology of the Democrats versus the ideology of the Republicans. That has always been something that has made it quite difficult to come to compromises with many Republican senators and House of Reps and governors opposing any national health insurance. So that has been something that's been playing a part. And of course, we have the lobbying that special interest groups have done, and very successfully also. The physician group used to lobby very heavily. They lobbied very heavily against Medicaid and Medicare, but somehow they lost. But we have had a lot of interest groups that have been able to, do a lot of pushback, especially when it comes to national health insurance. But regardless, some changes have been done, especially with Medicare, Medicaid, and CHIP. While that has not been a reform on the federal level, it has been able to improve access to health care, particularly for those most in need of it. Anyway, so prior to 1965, before Medicare, Medicaid came, things were not, going so great, especially for those who were most in need. What happened was that we had populations that relied on their own resources, whereby if you couldn't pay for your own doctor's visits and healthcare services, you had to rely on charities that came from hospitals or physicians. There were very limited public programs, and therefore people either had to be, able to pay out of their own pocket or be at the mercy of charity. And there was little to no assistance for those who were unemployed. If you didn't have any job and you couldn't, weren't getting any income, you just didn't have much, access to health care. Well, even back then there was private health insurance available. We did have Blue Cross Blue Shield was around for quite in the earlier days, but there were those that generally served middle class working people and families. People who were unemployed were not covered by it, and many people generally were not covered by it. And so that was a challenge for most people. And so market alone did not ensure access to care, and this is particularly for a vulnerable population. So without any government assistance or public program, market alone cannot help in making sure that everybody got access to care, or even it doesn't have to be everybody, but most people. This was something that the commerce and capitalism was not just able to provide in an adequate enough degree. So this still remains the case today, whereby market alone is still not able to ensure access to care for vulnerable people in the US till today. So, what has happened to Medicare? When Medicare came, with the 1975 amendment of the Social Security Act, the one that created Medicare and Medicaid. Medicare became something that individuals who were 65 and older became eligible for, or if they had disabilities and were eligible for Social Security benefits, and or people who were at end stage kidney disease. Those were people who became eligible for Medicaid. So, but you then had Part A. The Part A it covers healthcare services, some healthcare services, and partial nursing home coverage. This was financed through mandatory payroll taxes, and there was no monthly premium that was attached to that. And then the Part B covered physician services and outpatient care that were not covered by Part A, but they were covered. Enrollees had to pay some form of a monthly premium on that. Part C and Part D happened under ACA, which is why I'm not discussing that, but there was some kind of expansion that happened with Medicare after ACA. So with Medicaid, what happened with Medicaid was that Medicaid was specially designed for low-income elderly and non-elderly. So you would have some people who qualify both for Medicaid and Medicare, and that's because Medicaid focused on income. Eligibility was based off on income. And so, unlike the Medicare that was a federal funding, Medicaid is a part funding between the federal and the state that the enrollees are resident in. And so each state had its eligibility criteria and, what enrollees stood to benefit, and what the provider payment is, the payment that goes to the healthcare providers when they give healthcare services. And so some states we're able to establish and define other medical needs categories under Medicare because there were, different states kind of designed their own, so it kind of looked a little bit different state by state. But Medicaid had a few problems that was attached to it. For one thing, there was the stigma of being poor. And America does this very well. There seems to be a stigma around being poor, and you having people who are low income being represented as being lazy, not hardworking. So all of those stigma comes with being on Medicaid because of that sense that you're just taking from the hardworking people. So that caused quite a problem with that. And so what's also with Medicaid, it kind of ushered in a two-tier system in the healthcare delivery, whereby you have some states, in some states, people who are under Medicaid would not be eligible for some services because Medicaid is not going to cover those, and they have to pay that out of pocket. And if they're not able to pay that out of pocket, they get to not get those services, meaning that people who were privately insured had more access to services versus people who were under Medicaid. And then you then had the extra problem of some physicians just refusing to take Medicaid patients. And this is because the reimbursements for the services that come back from the Medicaid funding was usually lower than the one that private health insurance companies pay. So for physicians who know they're going to make more money from seeing privately insured people, it was more to their benefit to see those patients than to see Medicaid patients, which created some problems there. So then just very quickly want to talk about CHIP. CHIP, the thing with CHIP is that it's kind of tries to fill in the hole that was created by Medicaid, by the creation of Medicaid, whereby you had people who were too poor that they couldn't afford private insurance were covered by Medicaid. But the thing was, you had some people that were considered too rich for Medicaid, but they were not rich enough to be able to afford the private health insurance, or they did not have employee provided insurance. So they were kind of fell through the crack, and you had quite a number of people who were there, and that was where CHIP was meant to serve that population. So which means that some children from families who were covered by Medicaid do get to fall into CHIP, and so you could have children who are being funded by Medicaid in some low-income homes, and you have some children who were being funded by CHIP in some relatively low-income homes. So, and this was with the passage of the 1997 passage of CHIP that tried to cover up those gap that I mentioned. So now just going to talk about ACA. So the ACA, which you guys probably already know, stands for Patient Protection and Affordable Care Act, and was passed in 2010. Before ACA was passed, ACA had been in the making for many, many, many years before it was finally passed. And there was a lot of lobbying that had to happen with it, a lot of trading that had to happen with it. But even with the diluted version of ACA that we have today, it still kind of does what it was sort of designed to do, which was to relatively move the United States towards a universal and affordable healthcare coverage. That was the one of the key goals of the ACA, and also in trying to improve health outcomes and the performance of the US healthcare system. And then lastly, it wanted to address low rates of insurance among those in lower economic status. And it tried to do that through reducing the number of uninsured persons in the US and narrowing disparity in healthcare coverage, meaning you had many middle income people maybe having, let's say, 80% coverage of insurance coverage, and for lower income people you're having like 20% or 60 or 40%. So there was a huge disparity between insurance coverage depending on what your economic status is. So this whole bit about addressing low rates of insurance was the domain of Medicaid expansion. So that was one of the things that Medicaid expansion, was tasked to do. So there are other features of ACA. It expanded in employer mandates. It provided subsidized individual insurance that people could purchase through the health insurance exchange, and this was open for both private and public insurance markets. And one of the main thing ACA did, especially with private health insurance, is that they were no longer allowed to deny, limit, exclude, or charge more premium based off on what is called pre-existing conditions. So that went away with the ACA. Another thing that happened with ACA was you had mental health services being classified under essential benefits. That didn't used to be the case. So that was one other thing. And private insurance plans were now required to cover preventive care for children, something that they were doing before. And this includes screening and some preventive services. It also included hospitalization, prescription drugs, and a couple of other things. So in the previous module I did talk about state autonomy, or states having the right to veto federal laws. So I mentioned the states have autonomy, and part of that autonomy is that they retain the authority to request, accept assistance from the federal level, and delegate responsibilities and authority in the local agencies. So there is a degree of influence that federal policymakers or executives have on the states, but for a lot of the time, states kind of control what's going on in their states. So that's part of the autonomy that they have. And this also includes having the authority to reject or nullify federal laws that they feel is unconstitutional. So I want you guys to remember this because I'm going to kind of bring that up in a few. So states autonomy, how states are able to have this autonomy is because the state's primary responsibility is to promote and protect the health of their residents. This is a responsibility that lies with the state much more than it lies with the federal. So this is why they have this autonomy, and they get to also have the right to request assistance if they don't want that. So that kind of gives them. So where this comes into place with the post ACA, which I'm going to talk about now, especially with the Medicaid expansion. So with the Medicaid expansion, the expansion had some things that it really set out to do. Number one was to address low rates of insurance among people in the lower economic status that I've mentioned. Just wanted to reiterate that, and provide coverage options for those who are not receiving it from their employees or cannot afford to purchase their own. So another thing that happened, that changed with Medicaid expansion, was it used to be before ACA, Medicaid eligibility was solely based on income, but with ACA, it was expanded to include both income, household size, disability, family status. So there was a lot of other things that Medicaid eligibility, put into consideration when determining eligibility compared to how it used to be before the ACA. But when it comes to income-based eligibility, they are basically looking at persons that we are below 138% of the federal income level. This is not to say this applied everywhere. Do you remember I talked about state autonomy? So this means that states got to decide what their income-based eligibility was. But as far as I'm aware, no state have gone below 138% for those who expanded their Medicaid. Not everybody expanded their Medicaid, which I will talk about in a bit. So for states that expanded Medicaid, it differed from state to state. You had some states that were incredibly more generous than the other. And for instance, you had Washington, D.C., that was up to 319% federal poverty level. And we're also covering non-elderly adults that did not have children and have children, parents with dependent children. They had so much coverage for that. And then Michigan was doing a little less than Washington, D.C. at 195 percentage federal poverty level, while Oregon was doing better than Michigan, but there was something that Oregon did that none of the other states did, was that it extended their Medicaid eligibility to everybody regardless of their immigration status. This was something that Oregon did that these other states did not. So as you could see, some states were more generous than the others, and so it was eligibility under ACA still very much dependent state by state. So this is the current map of the states that have expanded Medicaid and those that have not expanded Medicaid. So if it's dark blue, they have expanded and they have adopted and implemented Medicaid as at 2022. Oklahoma, I believe, and Missouri have adopted Medicaid but have not expanded it. As at the last time that I checked the news, I don't think it's been implemented. Medicaid expansion, I don't believe it's been implemented in Oklahoma and Missouri, but I'm going to go and check that. But those two states have agreed to expand it. Louisiana expanded in 2016, I believe, either 2016 or 2017, but a little later than most of the other states. And 9 states refused to expand Medicaid. So they decided they're not going to expand Medicaid despite Medicaid expansion being a federal law. So remember, states have the autonomy to choose or nullify laws that they feel is unconstitutional. So this is some of the lawsuits that came as a result of ACA. You had in 2012 when the Supreme Court ruled that states were not going to be mandated or made to expand Medicaid. So if they didn't want to, they could opt out of it, and a couple of states did opt out of it. And then individual mandate was not removed, but there was no longer any federal penalty for it. There used to be one, but the 2012 court ruling said you cannot charge people for non-compliance for that. So, and this started in 2018. So in January 2021, the Supreme Court struck down the Texas legal challenge when there was yet another attempt to nullify ACA as a whole. The Supreme Court, voted against that. So these are some of the more very highly controversial lawsuits that have happened under ACA. And the expanded CHIP, CHIP has, like I said, CHIP has always been in existence, but with ACA, it got expanded a bit. So what happened with the expanded CHIP was that some states had the choice to make CHIP as part of their Medicaid expansion, or they could decide to have a separate non-Medicaid program that was completely separate from the CHIP, that was completely separate from the Medicaid, or they could have a combination of the two. So what happened with for the states that chose to have a Medicaid expanded CHIP, the states received funding to expand those Medicaid eligibility services, and then with states that had combined CHIP Medicaid, the states received federal funding to implement both the Medicaid expansion and a separate CHIP. So how they kind of differ is with Medicaid expanded CHIP, the children on it are eligible to the service, one of the screening preventive services, the early periodic screening, diagnosis and treatment program, which is mandatory. For those with separate CHIP program, it's not mandatory, and they have the benefits that they get under the expanded CHIP is a lot more limited and open to premiums and co-payments. So that's where we end. Oh, sorry, I forgot something. So 9 states have a CHIP expanded program, and those are Maryland, New Hampshire. 13 states have separate CHIP programs. Oregon is one of them, Mississippi, and then a couple of other ones. So that's where we end for today's class. Do have a lovely day. Have a nice day. Bye.